I'm going to talk about is neuroprotection, cooling and beyond. All of us are familiar with the consequences of brain injury. Apart from death, mortality, we also have neuromotor, neurosensory compromising intelligence, cognition, vision, hearing, seizure disorder, and also implications like neuropsychological, educational, behavioral problems of the family and problems of the society. Now, typically, when we talk about the situations of brain injury, we primarily focus on HIE. Although neonatal encephalopathy is a broad term which encompasses not only HIE but other scenarios that can induce brain injury in the newborn, although my focus is primarily going to be on neonatal encephalopathy caused by hypoxic ischemic encephalopathy. I'm just going to focus on basically pure evidence from the literature, and we'll try to cover some of the things, what's there in the literature and what's not there in the literature. We all know that we have approximately 25 to 27 million babies born in India every year, and worldwide approximately 5 tons of these babies are born and 4 million babies die each year before they complete 1 month of age, and 98% of these deaths occur in countries like India, and approximately 30% cases is because of birth asphyxia or birth injuries. We all know the SARNAT and SARNAT staging, but very few of us know that only there were 21 babies enrolled in this study that prognosticated the outcome. And then subsequently the paper by Levin which has about 128 babies where the modification of SARNAT and SARNAT is occurred. Now this staging is important just for the purpose of prognostication because the counseling will become a little easier for us. Now when you look into the literature, approximately 2000 paper from 2005 to 2014, and then when you look at the meta-analysis, if it is a mild encephalopathy, generally you don't worry so much because the risk of death or risk of neurosensory impairment is very little. But if it's moderate and when it goes to severe, we are in a problem. We know etiologies, it's more of theoretical, maternal causes, intraplacental and fetal causes. And we also know that the age, gestational age at which this problem occurs has the bearing on what happens to the fetus and the infant. If it occurs before 20 weeks, it leads to neuronal heterotopia and polymicrogyria. Between 26 to 36 weeks, we end up having periventricular leukomalacia, and after term, we get basically insult that primarily affects the gray matter and the cortex. Now, it's also important to remember in pathophysiology, there are several other factors that influence what happens to the baby. It is the cellular susceptibility. Neurons are the most susceptible because they are metabolically most active. And there are watershed areas where the blood supply is compromised. And also areas which have got higher metabolism, they are more likely to be compromised. And the severity of asphyxia, mild versus moderate versus severe, acute versus chronic, that also has the bearing. Now this basically slide shows the end result of hypoxia and ischemia resulting in free radicals. So all the therapies that we talk about are basically focused on inhibiting some of these pathways from adenosine to free radicals, from ATP to free radicals, and then from the nitric oxide synthase pathway, various molecules that are being considered. Now, primarily, the reason why we end up having problem is primary energy failure and then subsequently the secondary energy failure. And then when you look at various things that are possible theoretically might work, depending on what strategy you use, you can choose the molecule. And 2004, the first time review was done by Dr. Maguire to look for what works and what does not work in perinatal asphyxia. And then it was revised again in 2007. And that time basically treatments for unknown effectiveness, everything unknown effectiveness, unlikely to be beneficial. From then, a lot of things have changed. So let's look at whether you resuscitate baby, full-term baby in room air versus oxygen. All of us are now familiar that we need to resuscitate full-term babies with room air. If we resuscitate with oxygen, the mortality is 16.3%. Whereas if you ventilate them with room air, the mortality is 11.4%. The difference is 5%. And the number needed to treat is 20. Meaning if I treat 20 babies with room air, I would prevent one extra death that is going to occur. Broadly, although we are familiar with any problem ABCD, now we start to focus on temperature and I'll elaborate on therapeutic hypothermia. But this is basically a schema what all can be done: temperature, airway, breathing, circulation, drugs, medication, electrolytes, fluid, feed, communication, monitoring and follow-up. These three things usually we miss in a big picture. Anticonvulsants, when the reviews were done earlier versions, we said there is no role, but the recent review published in May, there is slight change in the recommendation, in the sense that there are more studies. In fact, near-term babies are also included. But what it shows that the risk of seizures, if you use anticonvulsant prophylactically, goes down by about 18%. So number needed to treat is 5. But we do not know at this time conclusively whether it helps for mortality and long-term outcome. But if you use anticonvulsant prophylactically, probably you would be preventing seizures. But actually whether this prevention of seizures translates into improved neurological outcome, that we really do not know. Coming to the only therapy that has been proven and practiced worldwide is cooling. Typically you would have babies who are having moderate or severe asphyxia who fulfill the criteria, who are enrolled based on your blood gas parameters depending on clinical features and EEG criteria. You would start cooling generally by 6 hours. You will try to reduce core active temperature to 33 to 35 degrees and approximately you continue for 72 hours. And basically how cooling works is basically it reduces the metabolism, it prevents edema, it decreases energy utilization, it reduces, suppresses the cytotoxic amino acids, it inhibits platelet activating factor, it blocks the inflammatory cascades, free radical injury prevention and secondary energy failure prevention, inhibits cell death and reduces the extent of brain injury. So in overall, until this review has been published in 2013, 11 RCTs, about 1500 infant enrolled. So basically, therapeutic hypothermia, practiced the way described in these studies, decreases death or major disability, decreases deaths, and improves the neurological outcome. So number needed to treat here is 7, 11 and 8. So basically only one therapy which is really helpful and works. Now the cooling is not without side effects. Of all the studies if you look across, the chance of having sinus bradycardia, heart rate less than 80 is about 5%, and chances of having thrombocytopenia, platelet count less than 1.5 lakh is 31%. But the requirement of inotrope or frequency of hypotension or cardiac arrhythmias is not really been higher in a therapeutic hypothermia group. We have few studies which are carried out in India from CMC Vellore and also from Hitmer, and many units in India already started practicing therapeutic hypothermia either with using of blanket roll or Neocon, and some are using cost-effective devices, phase changing material like what is called as Miracle. Now when the studies were published, there was a review, basically perspective given, editorial perspective, that there are ethical challenges that babies we treat here are not the same kind of babies that are enrolled in the studies in Western world, and probably we receive babies late, we receive babies hypothermic, they also have a comorbid condition like sepsis, so whether it is the right thing to do or not, and probably we need to generate our own evidence. If somebody is interested in reviewing just everything about asphyxia, just this issue of clinics in September has everything that is required. Now with cooling, we thought that if more sugar you put, more sweeter it becomes. So you cool for longer period of time and you cool for even lower temperature, whether this will work. So Sika Shankara's group from NICHD, when they did this factorial design trial, what they found is that typically whatever we are doing currently, 33 degrees, 72 hours, the mortality is 7%. But when you are trying to reduce the temperature to 32 degrees, or you are trying to prolong the duration, the mortality is going up. They were planning to enroll 726, but halfway through they realized that the mortality is unacceptable. So considering that there is a futility in attempting this, the trial was stopped early. They believe that probably not prolonged duration, number one, and cooling beyond 33 degrees is not something that is wiser thing to do. Now we have this follow-up data until 18 to 22 months, but what happens when the children grows up? So if you look into the original study by Sita Shankar and SCSD, they published 6 to 7 year data. So Dayton IQ less than 70, less likely to occur if you are pooled. Statistical significance is not reached because it's just a play of number. Although the difference here is still 15%, number needed to treat would be 5, the study would have been powered, probably we would have had a statistical significance. So less of death or severe disability, moderate or severe disability, and less of cerebral palsy. Similarly, the data from Tobit are, but although different ways the outcomes are measured, frequency of survival with an IQ more than 85 higher in the therapeutic hypothermia group. So we know that whatever is being tried and you are able to save the life, but you are not making them neurologically impaired even in long run, you are probably helping them. We routinely say restrict fluids to 2/3 standard operating procedure in most units, and like when you look, no study. So no basis for support. I think like we need to start with normal fluids. If baby is in shock, requires more fluid, we may have to give more fluid. If baby is having renal failure, fluid overload, we may have to restrict the fluid. But you cannot make a blanket statement that restrict to 2/3. Then coming to magnesium sulfate, study from J.J. Kashmir Institute published in Pediatrics by Mushtaq. But what they did is basically moderate to severe asphyxia babies, full term, use magnesium sulfate in a dose of 250 mg per kg as an IV infusion once a day for 3 days. And basically the way magnesium works, all of us know now, because it's been used in trial for PIH, it has been recommended for prevention of preterm birth brain injury whenever you are expecting a preterm delivery before 32 weeks. So 250 mg per kg per dose once a day for 3 days. It basically blocks the glutamate pathway and NMDA pathway. And although the outcome measure were only up to discharge, probably this molecule is being neglected because there is nobody has a financial interest in a simple drug like magnesium sulfate, which is only 10 or 20 rupees. Erythropoietin study carried out from China. Basically, we know that there are multiple ways the erythropoietin might work, and also it has got beneficial clinical effects. The effects are not only short term, but they are also long term. And basically what was done in this study was erythropoietin was given at a dose of 300 to 500 units per kg alternate day for 2 weeks, starting within 48 hours of birth. And in babies with moderate HIE, reduction was noted in death and disability to the tune of from 44% to 25%. So it looks like a huge number. The molecule looks extremely attractive. Similar study was done in Egypt. 15 babies enrolled, small study, published, but the outcome measure were only short term. And currently there are 2 ongoing studies. One is completed for NEET trial. They are trying to look which dose works better, 250, 500, 1000 or 2500 versus if you combine with therapeutic hypothermia, if you combine erythropoietin, whether that will work better. And 2 more studies are being in the process of registration with clinical trials. Allopurinol, 2 studies came in 2000 and then systematic review published. And basically somehow nobody has interest in this molecule, although probably numbers are very, very small, 28 here and 25 here. And what basically they found is that severe adverse outcomes are less likely to occur in an allopurinol group if it is moderate asphyxia. It does not work in severe asphyxia, although numbers are really very small to make any meaningful conclusion out of that. So basically, this molecule also needs serious evaluation. Mannitol we use left, right, center in pediatric age group, old era tuberculous meningitis. Only one study in the literature from South Africa, 25 term neonates, single dose of 1 gram per kg, and no difference in the mortality. This molecule generated a lot of hype in 2010 when the news came first baby with birth asphyxia gets the xenon gas in Bristol Hospital and recovers well. We know that xenon is an anesthetic drug. It blocks the NMDA receptor, it inhibits the AMPA receptor, and it inhibits the kinase receptor. So basically it is anti-free radical, anti-apoptosis, anti-inflammatory, so multiple mechanisms. And then several small reports, and then this small piglet study which there are 6 different groups where they randomized and found that basically if you use xenon it works. And then came this study published early this year where this was just a proof of concept trial. We are looking only at the surrogate short-term outcome, whether the MRI looks better or not, because doing a large study will be prohibitively expensive. So what was done in this study was 30% xenon gas, like we use nitric oxide, was used for 24 hours. Study was carried out from 2012 to 2014. Infants were between 36 to 43 weeks. 46 got into cooling only group and 46 into xenon plus cooling group. And 37 in the cooling group got MRI and 37 in the cooling group got MRI, 41 in the cooling plus xenon was the MRI. And what they measured was lactate to N-acetyl aspartate ratio. So if the lactate is high, the ratio will be higher, which is unfavorable. And then fractional anisotropy, which is just like how intact the brain is, but they have found no significant differences in that. The number of deaths were similar in the both group. So basically they stopped study in between because of the concerns that you probably are not going to find anything meaningful even if you carry this study and enroll the full quota of subjects that they were planning. If you have to do study for long-term neurodevelopmental outcome, you need to enroll 760 infants. And that was just considered not visible. So probably their concerns that they expressed are probably we started late because xenon gas was started median at 10 hours, cooling started sometime between 4 to 6 hours, so we started probably late. We used probably for shorter duration than what we used in the animal experiment, and probably we got our dose wrong because what was used in the animal studies was 50%, whereas here it was 30%. So currently there is another study which is planned called Cool Xenon 3, where they are going to do experimental cooling plus 18 hours of xenon at 50% concentration. And the other group will get only therapeutic hypothermia. We need to see what comes out of this. There are many attractive molecules. We all are familiar with melatonin, which is basically a hormone secreted by pineal gland which induces sleep. Multiple mechanisms, few animal data, and then there are 2 studies where they used it as 10 mg per kilo per dose every 2 hours, 6 doses, and found short-term favorable things. There are 2 small studies currently in progress, but people are excited. We do not know what the end result is going to be. We all know biotin vitamin, which is B7.
Only 2 minutes there.
Yeah. So basically this is a derivative of biotin, which prevents the formation of nitric oxide in the brain and the new inducible, and a lot of excitement around that. Then we have recommendation from NRP saying that we should not delay the cord clamping in babies who are asphyxiated, who need resuscitation. Whether we are doing right or wrong, there are 2 studies in progress for delayed cord clamping and umbilical cord milking. A lot of excitement with stem cell, acetylcysteine, and sedative analgesic drug dexmedetomidine and clomidine. And some animal data saying that basically plasminogen activation inhibitor, if it is given, it prevents the damage to the cortex. So this is the group who got saline, this is the group who got that. So basically in the end you left with baseline risk of death in moderate to severe HIE of 60%. If you do therapeutic hypothermia, you reduce 15%. So you are still left with 45% babies where they are either dying or they are having neurosensory impairment. Probably we need to find more molecules, more methodologies to treat them. And perhaps the wisest thing would be to see how we can prevent it, how we can prevent the birth asphyxia so that we do not have to treat this difficult thing. Thank you.
Thank you, Dr. Kabra. Since we are running short of time, there will be no question from audience. And the second topic of this session is use of neuroprotection